Welcome to the State of Mind virtual speaker series. This series has been developed to provide education and support to youth, caregivers, and educators during this challenging time. This series is a collaboration between two local nonprofits, 1 in 5 and Mindpeace, and various community mental health partners. We're glad you're here to educate yourself and to learn how to keep your brain in a healthy state of mind.
Hello, everyone. Welcome to our State of Mind speaker series. This is a collaboration between 1 in 5 and Mindpeace, and we are thrilled today to welcome Dr. Dan Nelson, who's going to be talking about coping with grief and loss. Dr. Nelson is the medical director of the Child Psychiatry Unit at Cincinnati Children's Hospital Medical Center and is a professor in the UC Department of Pediatrics. So, without further ado, I would like to introduce Dr. Nelson. Thank you so much for being with us here today and sharing your expertise.
Well, it's an honor to be here. And I do want to thank 1 in 5 and Mindpeace, not just for today, but for everything they're doing to help share information about grief and loss and coping, especially during the time of COVID. Thank you for coming to join us. What I think our format may be today is I have a few slides. I'll try to go through them fairly quickly so that we have lots of time to discuss what you guys may want to either share or queries that we might explore. Grief and loss is so profound in life experience. One of my mentors, David Fuller, a brilliant psychiatrist, was emphatic with my whole group that they said, he said, there's really not any psychotherapy or anything that we do to help people heal that doesn't on some level involve grief and loss. It's really pretty pronounced. So even if you're talking about somebody who maybe has diabetes, they've lost some of their functioning, right? Or I grew up with dyslexia and also hemophilia. And those two things really made me feel different than the children I grew up with. And so part of my journey in terms of coping with that was dealing with the loss of wishing I was, I'm going to say, normal. Of course, that left the barn long before. It wasn't just the hemophilia or the challenges with reading that have caused me to give up on normal for myself. So that's another story. Without further ado, as you said, I'll go to the second slide. I like to, a lot of what I'm sharing with you are kind of concepts or tools that I use in teaching medical students and even residents in psychiatry. And one of the things I think it's worth considering in any of our interpersonal interactions, this is true in the classroom, it's true in the family, it's true as we go through life in each relationship that we have, is that there are certain things that are present in our interactions that are, I think, more or less tools. So, you know, I'm sure you've heard it said, behavior speaks louder than words. When you're talking about helping someone change or whether they're going to do a task, their motivation for that task is fundamental to what's going to happen next. So in my assessment of children and families, I'm always looking for what's the person's motivation. We all also have a capacity for intimacy, and this changes over time. It changes over context. I might have a real high capacity for intimacy within my family, but let's say you put me in a new environment where I feel anxious. It could even be a party with people that I might only know indirectly. I may not be able to open up with those people, and it may actually be healthy to pull back on my capacity. The capacity or readiness for change, if someone is in a situation where you're asking them to change, and sometimes we get into these places with grief and loss that we feel stuck. And so to understand when is the best timing, trying to teach a child to read before they're age 5 is best done not by having them read or even necessarily identify letters. It's just about talking to them, reading books to them, making books enjoyable, and you lay a foundation for when their eyes are going to mature. Because if you try to do it before 5, it won't be very easy because they can't see what we see. So when you know someone's ready for change, when you know they're ready to cope with grief and loss based on where they are. So if you think about when there is a profound loss, such as a death in a family, there are actually rituals to help us and help the family to go through that. And the journey is much longer than just the structure we have culturally to get through that. Most people will tell you 6 months to a year is needed to feel adjusted to profound grief or loss. But I'll also tell you, almost everyone I've spoken to who's lost a child will tell you, in a way, their life is never the same. And so you begin a new life that involves a part of your heart, I think, that some people would say it feels as if it's missing. And it's important for us to be sensitive to how various people and various cultures might find themselves relating to not just the tradition and the culture of grief and change, but that individual's orientation and how they feel they might adapt to it. Another tool that we all have is ability to self-reflect. How well do we know ourselves? And how much can we think on that, have a perspective on that, be able to talk about our thoughts or feelings with others? Authenticity is a dimension that involves, as we go through things, are we able to speak kind of straight from the heart versus various filters that are there. And it's important, it's not a criticism, but these filters are needed more or less to protect ourselves. Sometimes these have developed from past experiences. Some of them may be very useful in the here and now. Some of them may actually be, as one author wrote about it, rusty armor, a way of defending yourself. Now you're carrying this armor. It's not really helpful. And if you can take it off, you can be free again. The concept of deceit in relationships is kind of interesting. Most people don't realize it's adaptive to have some level of deceit. Not just white lies, but if I'm in a situation and I don't want to reveal how I'm feeling, maybe I'm feeling a great deal of sorrow or sadness, and somebody comes up and goes, "Hey, how are you doing?" And they're not looking for me to unload a profound narrative on what I'm going through. They're just like, "How are you today?" And the traditional response is, "I'm fine, how are you?" And I'm not fine. I might actually feel like crying. I might be working really hard because I don't want to expose myself in the context of that situation. People also may need to say, I went to a wake last night. And this was a dear friend of mine, and he was the father of a close friend. And he had struggled with addiction, alcoholism. He's 85 years old, and he lived a fantastic life. He lived through World War II. But the last years of his life involved addiction. And as we went around, there was a small group of us, and as we went around to talk about this fabulous person, I found my own authenticity. I found that I wanted to acknowledge the challenge he had with trying to overcome addiction. And I thought it was part of what led to his death. And I wanted to acknowledge it. But at the same time, I noticed other people who were aware of those negative things weren't talking about them. Wakes tend to be very positive, but in my mind, being present and supportive of his challenges with addiction. It's not a criticism of him. It was a supportive statement of, just like he lived through the war, he lived through this personal challenge. And addiction, believe me, if there's something that creates grief and loss, it's addiction. I think most people who've been close to any form of serious addiction will tell you there is no problem so great that drugs or alcohol can't make it much worse. So, feelings, how we perceive our feelings, how we share feelings is definitely part of the legal tender of how we reveal ourselves. Mood is a larger context of how we feel toward the world and ourselves. So feelings are kind of more like, what's the weather today? Mood is kind of like, what season is it? And in some ways, at least how I think about it as a model, affect is kind of more like, what's the climate? So there's kind of 3 levels of how you might examine your feeling states. Relationships are tremendously important in grief and loss because it's from relationships that we draw strength and support and resiliency. So looking at each other and sharing a concept, or at least trying to evaluate a concept of how do we know each other through the context of what is this person's relationship, not just within the family, but our faith-based relationships, are the people with whom we feel we can be open with and confide, the people we can ask for help. And then insight and judgment are, of course, often, very important when it comes to reasoning. So one of the ways I feel like to go to a child's point of view, which is the next slide, I'm a child psychiatrist, so I think it's worth, if you're working in the schools, if you're working with children, or even if you're working with adults who have children, having some knowledge about development and how kids deal with grief and loss, especially death. From an early age, children will pick up on how grown-ups behave, how they speak about these things, and how they begin to problem solve in front of the child. And if all this is pushed away from the child as if they're not to know about it, what they pick up on is the grief and loss is happening, the situation is happening, but they actually perceive the adults to not necessarily be competent. And I'll give you an example with some of the work I've did through the National Center for School Crisis and Bereavement, is we've gone to a number of disasters, and there've been a pretty horrible disaster that involved a shooting in a movie theater. And I was working with the superintendent school with a dear friend of mine, David Schoenfeld, who is the director of the center. And we were several days into it, and one of the people working there said, I have this granddaughter who has been really sheltered from being told about what happened. And, or so they thought. And they wanted to go to a movie, and the granddaughter, it was a movie, the whole family had gathered around the table and, hey, might we go see a movie today? And the little girl just stood up and immediately said, no, we're not going to a movie. Movie theaters are really dangerous right now. She was 5 years old, but she'd gone to her swimming lesson. And guess what the 5-year-olds were talking about? The same thing everybody else was talking about. So it's important to realize kids, it's very difficult to shelter them from everything. What I think of as a more useful concept is filtering things and letting things through that you have a sense that this particular child maybe can cope with. And then maybe let them try that on, and then helping them cope with it better, or trying the next thing. So they need to talk about death. All of us do, I think. Putting the cards on the table is an important concept I use with trauma patients. Is if the cards are jumbled and they come up, you're flipping them, and you suddenly are impacted by that event. Let's say each card is a memory, and let's say the face cards are difficult events, and the aces are really traumatic events. If you think of yourself playing solitaire and you're putting down these cards, as you have an opportunity to look at that card and understand it in the context of, let's say, the other memories in your life, you begin to organize those things. And hopefully, if you've had something that's led to PTSD, you have somebody with you who helps you identify, hey, this is where it fits. And at the end of the game, the cards aren't coming up at random, right? The 4 suits are organized all through this. And my experience in working with children and even adults with traumatic experiences is, once we get through and we look at the narrative around each of these traumatic events, it's not that they disappear. It's like when you clean your closet. When the closet's so dirty, you open it, or not so disorganized, and it hits you, it floods you. You take a few days to clean it, and then the things are still in there, but they're organized, you know where they are, where to find them. Adults can lead this interaction by openness and active listening. And what's meant by that is knowing something about what needs to happen, what the individual needs to work on, and maybe gently guiding them either towards something, or if it's overwhelming, gently guide them toward what are the supports, what are the coping skills that go with that. It's very important to avoid platitudes or placations with people. I think we have a tendency, some of us might have grown up hearing these things like, oh, I know just what you're going through. I don't think that statement is hardly ever true. You could be a twin experiencing the same thing at the same time, and you wouldn't necessarily know what this other person is going through, because we all think about things differently. It's much more powerful to say, I know this hurts, or I can see this is difficult, is probably more powerful than pretending to know. To say, I see this is a challenge, and or I know it can be hard to go through what you have. So very briefly, the brain is organized really in two ways: feeling and thought. This goes clear back to the Greeks. They came up with eros for feeling and logos for thought. So these are the structures in the brain. The limbic system is the emotional center, and it's an older part of the brain. If you can see my cursor, this is all centered around the very core of the brain. This is the spinal, this goes down to the spinal cord. But deep in here, the hippocampus, the amygdala, these structures are used for organizing memory, recognizing a stimulus. What is the emotion that goes with it? The more recent levels of the brain are this outside area, what we call the cerebral cortex. And this is where humans are markedly distinctive in terms of how well our brains work relative to other species, because we have by far the most developed cortex. So as you listen to people talking and coping with loss, you'll begin to get a sense of how do they organize this. And we have always been storytellers. So you'll see here, the story has a line. It's what we see in literature and film. It's what you hear in songs and ballads. And it's intrinsic to our trying to understand ourselves and others. If you can understand, there's really three roles that typically go into stories that are, in a sense, initial, kind of the opening melodramatic. So you can see here, oh, maybe you can't see my cursor. There you go. See these guys up here? They were storytelling a long time ago. But this storyteller here is you're gonna have these three elements, and it's the victim, the villain, and if you have any one of those, you're gonna have the third: victim, villain, hero. So as you listen to people tell their stories, you'll begin to see this. Now, if you're hearing a story and there's a lot of story about I'm the victim and here's what the villain did to me, you are being assigned as the hero, whether you're aware of it or not. And there's limitations to that. It's important to be careful with that. You may think you want to be the hero, but in a sense, it's better to move the story out of the context of having these assigned roles so that people can be their own hero, and that they can also recognize that we have a tendency, all of us, to victimize ourselves by the stories we tell. We get caught up in them, and then we continue to do things that capture a re-experiencing of a victim role, for instance. So these are important for relating the human condition. They're important for making them personal and unique to me. And they're really how we learn things, the stories. In fact, I'm telling stories right now. There's, we could look at this triangle in the way that I'm talking about. So now we get to unpacking the story, which is that little bit I had about what we might do with the cards. How do we present? It's not my deck of cards. A good clinician or a person who's wanting to come in and provide appropriate supports, it's important for us to recognize that if I'm going to guide someone through a difficult passage, I'm more like the wagon train guide, right? I'm more like the trail boss with the people going on the Oregon Trail. It's not my wagon. It's not even my horses. I don't necessarily decide what's in the wagon. I don't decide what gets thrown out of the wagon when they decided they put too much in there. I'm the person who's like, I've been down this path before and I can help inform this. It's important not to interrupt, but have a sense of where people are. And it's very important to recognize what it is the person really is talking about and where are they. Be with what is a concept I give to the people I work with. Don't try to assign good or bad. Just try to understand what is. What is this person? Where are they? And how can you be present to them as they go through this? So I can see you're feeling sad. It's okay to wait for the words to come. They might be crying. That would be a phrase I might hope to say. You can always get lost. So Gerard Manley Hopkins, I was thinking about my own experience about learning about loss, and I went back to high school. Margaret, are you grieving over Golden Grove and leaving? Leaves like the things of man. You with your fresh thoughts. Care for you, can you? This is a beautiful poem, and this guy was not known. He wrote this back in the 1880s. Hardly anyone knew what a great poet this guy was, but after he died, they really found that he was one of the best poets of his era. And in this, he really says that, you know, she was crying, this little girl was crying over the leaves falling. And he was touched by this, but when he thought about it deeper, he realized, at least from the point of view of the poem, is that we all have to face that we're all going to die. And so on some level, when we talk about grief and loss, there is a poignant aspect to this, is that no matter who we talk about or who we've lost, we will all go through this. All of us will be invited or challenged, if you will, to lose the people we love, unless it's our fate to die before they do, and then they lose us. And I think there's a lot of other cultures that recognize that birth, which we tend to think of as wonderful, not always is that true, but often it is, and death, which we often think of as tragic and undesirable, they're merely the opening chapter and the final chapter of the book of life. They're bookends. Neither one is neither good nor bad. However a person is born, however they die, is just how that book is. We grieve sometimes because we think the book shouldn't be that way. This should not be the story of this person's life. They died inappropriately, or they died far too early. But in fact, it will be what it is. And so to adapt to it in terms of appreciating that person's life for what it is and what they gave you and what more we would have liked to have shared is important. It's an important story, but it won't change what the story is.
What? No.
So then here's thought and feelings. And what I would say about the feeling part of our lives is it's kind of the compass, and the thought is the map. Another way to put it is, what do you want for dinner? You're probably going to pick the thing that you want to eat, that feels good to eat. And then you might think, well, no, I need to tone it back. There's too many calories there, or I'm going to save my appetite for dinner or whatever. What career do you have? You probably picked it out of your passion for that, and then where you studied or what you worked at or how you began to learn the tools for that. That's thinking. So feeling is in some ways it's a leader, but not always. But it definitely is where we get our passion for what we do. The thinking is how we then negotiate that. So it's the narrative that has both thought and feeling that's balanced. When you hear someone speaking and they don't have that balance, you're not hearing the whole story. It's not that it's bad, it's not that it's wrong, but I think it's important to know when there's maybe part of the story that's not visible, and it's an important part of the story. So that's sometimes what we need to do, is invite people, and some people have a limited capacity for this. I might have a limited capacity to be able to give the narrative, to talk through what I've been through, but I might be able to share with you my feelings. I might have a ton of feeling and not be able to tell you much about how I got to this place. If we can begin to explore those two and let them integrate, is when we begin to see a much more healthy balance for that particular individual. So we're almost through the slides. Before we can understand other people, we have to understand our own selves. And this is real important. If you're with someone who's got intense feelings and you don't know what you're feeling, and furthermore know where that feeling is coming from, you yourself, you're probably going to get disoriented in some way. And you're going to be saying things that may not be as important for that person in that moment. You've left being with what is, and well, in a sense, you're not being with them, you're being with yourself. And you may be trying to fix something in yourself or deal with something in yourself. Unknowingly, you're throwing that out for this other person, and it's maybe not a good fit. So this is a fundamental principle for good interaction, is know what you're feeling and where it comes from. And this is not a new concept. You can see when Plato wrote about Socrates, he said, understand or know thyself, right? You can see here's a person, they've taken their face off, they're looking at it. It's kind of a strange image, but I thought it fit. And then Shakespeare, 1,500 years later, he says, this above all, to thine own self be true, which is a little bit different, but just as important. And knowing ourselves and knowing who we are and then who we want to become or where we want to go And being true to that is I think, his invitation for how to live a better life. So reflecting on our own past experiences, reflecting on what's intrinsic to the person we're with, be it a child or an adult, a parent, an aunt, an uncle, a grandparent. And the real trait of this, when I talk about feelings, it's real important to have a skill set where you can recognize the primary emotions. There's only 7 of them: anger, sadness, anxiety, and fear. They look the same: surprise, joy, disgust, and contempt. And when I do lectures on this, I mean, this is really kind of like when I was in medical school, this was 30 hours of our training in terms of understanding our interaction with patients. But if you can understand what a person's feeling by recognizing the facial display, this is hardwired into our brain. And, you know, one of the things I share with the physicians I work with is that when you ask any question, you're going to see this emotion as a flash before anybody utters a word. And that flash has more direct communication than anything else you're going to hear because it's unfiltered. It doesn't have the editor. Now you're going to hear a story, or maybe you won't hear a story. You might even see a whole different emotion that the person wants to show you because they don't want to show you emotion B that was the first one's where the authenticity comes from. So that having been said, I really want to thank you all for joining me. I think we can either move to a discussion or questions and answers. We can go any direction you would like. Joan, I think, weren't you here a week ago?
No, I was not.
Oh, okay. Well, welcome. I'm glad you're here. What would you guys like to talk about? Because we can talk about what's in the slides. We can talk about anything you're thinking about when it comes to grief and loss. And we can even go off topic if you want.
I have a question, Dr. Nelson. Can you talk a little bit more about anger? Because I hear sometimes that that's considered almost a secondary emotion. And there's something else sometimes underlying anger. What are your thoughts on that?
So the evidence, I could give you my personal thoughts, but I'd prefer to give you the evidence because this is well studied. Primary emotions are all, if you see them in that flash, they're definitely authentic and they're primary. They're fundamental what's happening in the brain. There's a neurochemistry for each of these. There's what we call prosody, which is the musicality of our language. But it's true what you have been presented, that if I'm more guarded, I feel less comfortable as an individual with maybe displaying fear or sadness, I will cover fear and sadness with anger. To give you a real frequent example of this, there are emotions that different cultures take a pejorative stance toward. So in our culture, the United States, and maybe a lot of Western culture, men are ridiculed for displaying anxiety or fear or sadness. You know, and often it's approached with young boys by ridiculing them by acting like it's bad to be a girl. You cry like a girl. It can also be that I just don't want to tolerate the emotion. That the parent, would go, I'll give you something to cry about, right? Or you're a sissy, right? Sissy reflects the feminine. And there's nothing wrong with being feminine. There's nothing wrong with running like a girl. There's girls who run amazingly well, right? And it's not a male-female thing. This is kind of a misattribution as far as I can see. Similarly, there are emotions that are admonished in women or girls. Can you give me an idea what emotion that might be in your experience or the experience or observation?
Dramatic and often emotional.
Well, actually, women are given more latitude to be dramatic and emotional than our males.
Oh, they are
right?
aggressive.
Given
They're not given a lot of attitude to be aggressive and
aggressive.
ambitious.
So which
Sure.
of the primary emotions are you talking about?
Probably more things like anger.
Anger. So
Yeah.
men who want to mask or cover their sadness, fear, or anxiety even might come across as really gruff, right? And angry in the way that you talk about, when the anger is not the primary emotion. It's a cover. Women, on the other hand, women who display anger, how do they get beat up? What kind of names are we give women who are angry?
Names that I can't really say on.
Right. You don't want to say on a webinar, but could we say it rhymes with witch?
Yes.
And that's a very pejorative term, right? And so women at an early age learn not to display anger. And I can tell you, I've worked with many, many people, and they're crying. In fact, if you will, look at this slide. This little girl, what do you think she's feeling? She's crying.
Mm-hmm.
But
She's angry, though.
That is not sadness. She's experiencing anger. And, you know, when kids display this stuff, it is robust, like you were saying. Hey, it can be really animated. It can be dramatic. And a lot of people will want to shut that down, as opposed to, how do I help a child understand their feelings, understand what to do with it, and understand when they need to modulate it and maybe when they don't. Because when I'm with somebody who I really trust, I might be able to show anger or sadness at a high intensity and know that they will use that to better understand me. Some families don't put up with much display of feeling. And if you go to it beyond a certain intensity, you violated a family norm. Certainly business places, professional settings only tolerate so much feeling unless you're acting or something, you know. And again, there have been settings, I'm not saying this is at all helpful, but there have been settings where men might display a lot of anger. Like when I was training as a medical student, the surgeons would sometimes, I couldn't believe how angry they were. And they would throw instruments across the room because maybe their perception was somebody wasn't doing what they should be doing. And I'm looking at the person they're mad at going, God, they look like they're trying to do the very best they can. And we now teach not to do that, that's detrimental to the task at hand. It's not helpful. You wouldn't want that to happen in the flight cabin of your plane. You know, if you're flying a 747 and you hear the captain screaming at everybody and throwing stuff, you think, oh my God, we're going to crash. So it doesn't belong in the surgical suite either, but it was done and it was accepted. I'm sure it's true in military settings too, big displays of anger. And I'm not saying you can't share anger anger is a very authentic and intimate feeling. It's actually very important. One of the things I will share that I learned in medical school was, you know, what's the opposite of love? What would you say?
Disgust or hate?
Yeah, that's what I would have said, because I went to a state school. And that's what I would say on the MCAT now, or not the MCAT, but the SAT or the ACT. But in fact, in our life experience, and you don't have to share this, but if we step back and consider, who have you been most angry with in your life? Might it be your parents, siblings, even your children, people with whom you work? It's not the people you don't know. It's the people with whom we have intimacy that we get angry. So love and anger, or hate, love and hate, anger and joy, they're a vine that grow around the tree of intimacy. If we get close to people, that's the people who are going to step on our toes, right? If I'm close to you and we're dancing, you're going to be the person who steps on my toes. And when you do, I'm going to be mad about it. I might be hurt, but you know, and I think when people recognize, oh, this is part of the topography of close relationships, then the question becomes, how do we accept that we're going to get angry at each other and deal with it in a really positive way? It has importance. It needs its supportive functioning so we understand each other and we can respond to each other in a healthy way. The anger is not unhealthy. what becomes unhealthy with anger, sadness, fear, any of these primary emotions is our inability to respond to them or talk about them, communicate, understand ourselves and each other. When you're not understanding the feelings and you're not able to communicate even with yourself about it, that's when they become problematic. And when I say problematic, it doesn't start out being a big thing. It's a flat tire. But do you want to drive your car with a flat tire? How safe is that? And to fix it, it might not be a big deal. It might just be put air in it. When I was growing up, I didn't have money to fix a tire for a while. I put air in my tire for about 3 weeks, every day. I put about 40 pounds in it. And by the next day, there was only 20 there. And then I go back and, that's my way of temporarily dealing with the problem. And then I saved up some money. And actually at that time for $5, you could plug the tire. But the tire was almost bald. And so I saved up more money and I bought a tire. Now, all three of those solutions allowed me to achieve safety, because driving with a flat tire is a very different situation than making sure the tire has enough air for however you can, and then eventually dealing with the problem definitively. And so these emotions are kind of like that. Sometimes we know we're mad at someone we love or care for, someone with whom we're close, and we maybe just put the air in, but we're not doing the definitive answer. And that's not altogether bad, because sometimes there's other pressures, there's other things that need to be addressed. But at some point, at least what I would hope for most people in their relationships, and the grief and loss function in the same way, we can kind of do a delay thing, but ignoring that the tire is flat or losing air. Now I'm driving this car and it's unsafe. Maybe it's my right front tire. I go around a corner. Next thing you know, now the car has hit a telephone pole because I couldn't turn adequately. And we're not talking about just go to the station and put air. We're not talking about a plug or a new tire even. We're talking about maybe the telephone pole hit another person. Maybe somebody in the car got hurt. By ignoring a problem, it can crescendo into something. I was a firefighter for a time, and I tell my families now, please tell me as soon as we recognize there's a problem. I like putting fires out when they're small, not when they're big.
Thank you. Does anyone else have a question? Any participants in the webinar have a question for Dr. Nelson tonight? Feel free to unmute yourself if you do.
Can you hear me?
Yes, Louise, thank you.
Oh, thank you. I am so sorry. I have just received 3 phone calls, so I have missed some of the questions that have been asked to you. And so I hope I'm not repeating myself here with a quick review, if you will, of the stages and the journey of death in a family.
Well, often when we hear stages associated with death and loss, we think of Elizabeth Kubler-Ross.
Right.
And she's a lovely person. I got to study with some people who had worked with her directly. And at one point I was involved in a project when I was in training. AIDS was kind of blowing up, and we did a large project. And one of my professors who knew her well invited her to come help us with this project. And she didn't come, she didn't get to, and I was sad about it. So these stages that she talked about in her book, Death, on Dying and Death and Dying?
I think
Death
so.
and Dying.
Mm-hmm.
Death and Dying. She talks about them being sequential, and I think it's important to recognize they're not altogether sequential. The first stage is where we just don't even believe that this has happened, okay? And so if you want to consider, let's just take an event like 9/11. We're watching the television. I was at my work and someone turned on the television, and here's this building and the plane's gone in there, and you just didn't want to think anybody been hurt, but how can that be? So denial, right?
Right.
And then the next phase of denial, because you're kind of like, well, how does a plane hit a big building like that, right? But you're thinking it must be an accident. And I was listening to the commentators say this stuff, like, how did this happen? Did something fail in the guidance system and everything? And then, of course, as we watched, another plane went in, and our worst hopes, our worst fears were confirmed that this is an intentional act, and So the next phase is actually anger. Anger is a defensive, protective. So in the course of my working with so many people with these challenges, I will tell you that the anger can be at the person who has passed. It can be anger at anything, any factor, anyone who caused it. It can be anger at God or whatever your faith is. And these things to various, and then it can be, then you can just begin to get anger indiscriminately. So if I'm not able to process my anger and I'm not getting support in it, I might show up at work and just start getting mad at anybody. Or I might just get mad at people in the house, people with whom I love. But because I'm not processing it and I'm not identifying the real source of what the threat was, because anger is actually about threat, it begins to spill over, what we call displacement. So the next phase is you're trying to get out of this. You're trying to worm out of it. It's not going well. You're in pain. The denial didn't work. It's still coming at you. The anger didn't work. You want to attack it, but it's still there. So then you're like, okay, I'm going to make a deal. If I do A or B, can I get out of C? Can I get out of death by, I've had a woman who was fairly old, and she wanted to live long enough to see her granddaughter get married, right? And so she was like, doctor, I wasn't the oncologist, but I was part of the team. Doctor, can I just get me 6 more weeks to the wedding? And the team worked really hard, and all the hospice kinds of stuff and the chemo and everything. And she was able to make it, and she attended the wedding. And then she came back to get her continued treatment. And she looked up at the doctor, the oncologist, and she says, I've got 5 other grandchildren.
Mm-hmm.
So in a way, she had this, what we would call magical thinking, that if I have enough of a reason to live, can you get me a reprieve? And unfortunately, she was terminally ill, and that wasn't possible. And if that works, great. But usually if we're dealing with loss or grieving, the event has already happened and we're just trying to reshape it. Now, when all that fails, and if you've worked hard at those other things, you're going to get hit even harder with sadness. That's the 4th stage. And that's when it's just real. Now you're in the room. Now that person is being with what is, okay? And what's interesting about that phase, people think that's by far the worst phase, right? That's when you're suffering. But suffering is how we deal with loss. That's the natural response, is to experience pain and suffering. If it's something you care about or someone you care about and it's taken away from you, you're going to suffer. You're going to feel sadness. You're going to hurt. And what's interesting is when you join that process, it's from there that you begin to learn how to cope. Until you get there and you get in the room, you don't get to the skills that allow you to cope and function at your best, having been transformed. Because if you lose something that's a part of you, right? If this person is so important to you, and it doesn't have to be a person. I mean, if I went to work tomorrow and they told me, you can't work here anymore, and I would feel the loss because I work at a children's hospital. It's amazing. But let's say it's even bigger and they say, you don't get to be a doctor anymore. Well, I love being a doctor. I don't want that taken away from me. I would be devastated. And you can bet I would be pissed off. But eventually when it sinks in and it's like, this is gone, you're not getting it back, there's going to be tremendous sadness. But until I embrace that sadness and I cope with it, then I reinvent myself. Yes, part of me has been taken away. It's missing. Same thing. I had a patient recently. There was a lot of shootings in our town. She was driving with her husband and her daughter. This is such a tragedy. And her windshield, the passenger windshield shattered, and her 2 fingers were gone on her left hand. Just the bullet just took them away. And in talking to her, she just said over and over, I'm so glad my son wasn't hurt. He's a baby. And so it allowed her, but at some point I'm thinking, and I'm sure she is too. At some point I'm going to miss these fingers. But at that point, she was going to make it positive. I didn't lose my son. I didn't lose something far more precious to me than this part of my hand. And we do that. In a sense, it's a way of bargaining. Because eventually you go, well, my son's fine, but I lost my hand. I can't use my hand in the way that I could. I think she's been very generous in sharing the story with a bunch of people I train. I hope she's okay with me sharing that with you. Because I didn't get a chance to ask her about it, but she's a very, very generous person with her experience. So things hit us. And once we deal with the sadness and we redesign who we are, we've been transformed. That's acceptance. And it's from that place we can go into the world and be strong and healthy again. We're not seeing ourselves. We've learned from it. We've accepted that it's happened. We're not wishing that it didn't happen. We're coping with, this, I am transformed. I can't be the person I was before. But now who can I be? And in some ways, I mentioned my hemophilia and my dyslexia. Now those made my childhood really difficult. But growing up with those challenges, both mental and physical, have been so very helpful in understanding my patients and being able to listen to their experience and have a correlate with my own, such that I can go, some part of me knows I really need to listen closely if I want to understand how hard it was for you. I know it was hard for me. Mine was different. But if I listen closely, and by adapting to my own, it made it easier for me to go into their space, their world of how they feel and what they're experiencing, because I can allow myself to go there, having developed my own resiliency for similar experiences. So those are the big four.
Thank you. I really appreciate it. That helps a lot.
Denial, anger, bargaining, sadness, and acceptance. The interesting thing is, no matter how good you are at that one cycle, it's coming back, baby. We all get to go through this many, many times.
Well, and you talk about how it doesn't just have to do with losing people, but losing experiences even. And I think a lot of people are going through this process, I wonder, just even with the pandemic we're going through and all of the losses, even if it's not the loss of someone they love from the disease,
Absolutely.
But just loss of experiences.
That is a great point. The loss of experiences. My wife and I have already had COVID. We went to visit a friend another physician who has pretty much been alone in her home for a long time. And she knows science pretty well. And it's really difficult, thankfully, for people to get COVID twice. I won't say it doesn't happen, but it's like a lightning strike. Do you not go leave your house thinking you're going to get hit by lightning, even if it's raining? You put on an umbrella, and maybe you don't go out when you hear thunder. So current evidence suggests that you're very unlikely to get COVID twice. So she was happy to hug us. And after she did that, she stood back as we were leaving and she goes, you can sell those hugs right now. Because part of what she was acknowledging is this physical contact we have. I talked to my medical students today about the meaning of shaking hands and how important it is. Our hands have a lot of sensors in them. And when I say to somebody, I know and trust you and I want some kind of relationship, like people we shake hands with, we're in a relationship. And there's this physical touch contact that happens that says, I know and trust you. And we think about how they shake our hands and do we look them in the eye, to say, I want to know what you're feeling. And, that's really a profound experience. And I hope we don't lose that when COVID ends, because it's wonderful technology. And culturally, I think it's important. And I don't want our fear of contagion to take over this form of social intimacy that we need with other people with whom we just need to come up, maybe they're not my family. Maybe they're just like, I shake hands with my plumber and if I see the trash collector, I used to be a janitor. I want to shake their hands even then if their hands are busy with other things, a bump or, I told my daughter, who's a medical student at this time, I said, now when I talk to patients and they're doing a good job, I know they're hungry for this touch thing. And so we'll bump hands. And I said, on the average, I'm probably bumping people's hands in a session 8 or 10 times. And because I'm going like, good job, boom, boom. And of course I work with kids, but I also work with people with addiction. And I said, the funny thing, I keep waiting for them to go, like, what's with all the bumping? But nobody's saying that. And of course, for me, I'm bumping people's hands like 60, 70 times a day. So I'm kind of like, bump, bump, bump. But I know we need that. I know we need that contact, but it's not the same set of sensors. It's not the same experience. Hitting an elbow, or I'll just say, hey, COVID handshake, because I want them to remember what it was. But I'm seriously sad if 5 years from now, a third or a tenth as many people shake hands because of COVID, which may be the case. We'll have to see where we go. I will have to grieve that.
This has been wonderful, Dr. Nelson. Do you have any more questions, Louise, for Dr. Nelson?
No, I'm good. Thank you very much. This has been very, very, I've taken long pages of notes. It's been very helpful for where I am right now in life.
Well, and if the slides are at all helpful to you, Louise, or anyone else who's listening, 1 in 5 have the slides. I'm happy to have them shared with anyone who wants to use them.
Excellent. Thank you so much.
You're welcome.
Yes.
Have a good day.
You too.
Thank you, Dr. Nelson, very much. Thank you for this presentation, and we will look forward to the next one with you.
Very good. Thank you. Good night.
A special thank you to our State of Mind speakers and to you for joining us. More videos and educational resources can be found at 1 in 5's website. If you feel like you or your child is in need of professional support, therapists are available. Please refer to MindPeace's school-based or community resource page. For a mental health crisis or emergencies, patients and families are encouraged to contact their current mental health provider first. This allows the mental health provider who knows your child best to provide support and direction. If your child does not have a mental health provider and they are experiencing a non-life-threatening mental health crisis, you are encouraged to contact the Psychiatric Intake Response Center at Cincinnati Children's Hospital Medical Center. 513-636-4124. Call 911 or go to the emergency department if you are experiencing a medical emergency, a life-threatening mental health crisis, or are directed to go there by a medical provider. This will help limit the spread of COVID-19 in our community and allow our emergency departments to care for patients with the most critical needs first.